have an 86-year-old Caucasian female with the chief complaint of I have been a little forgetful lately. She is referred to us by the Office on Aging for evaluation of memory loss. The onset is 6 months ago, reported no memory loss prior. It's unprecipitated by events, and nothing makes it better or worse. She has intermittent episodes of unknown duration and occurrence. The symptoms are also unchanged at different times or days or seasons. She describes it as, quote, trouble concentrating, inconvenient, but nothing to worry about. I'm just older and I don't have an illness. Past medical history is none. No known allergies. Medications, no herbals, no over the counters, no current prescribed meds. Family history, mom and dad, deceased in their 50s, unknown cause. One sister alive that's in good health. No children. No familial psychiatric history, and history of familial dementia is unknown. She's a retired typist. No alcohol, no tobacco, no illicit drug use. She does 1 cup of coffee and tea in the morning. She eats a balanced diet described as strong, a strong appetite, eats lunch with her friends at the Senior Citizen Center. No travel, spouse deceased, no family nearby. She does live alone, doesn't drive, friends help with the groceries. She's Catholic, does not attend services any longer, but a priest comes to visit her and she has forgotten his name. The Office on Aging worker is accompanying Ms. Cantor Day and reports that she's been neglecting her finances. She has unpaid bills, overdrawn checking account. Her apartment is quite messy, remnants of meals, trash, and spoiled food scattered about the apartment and in her refrigerator. I did a comprehensive review of systems, however, I'm only reporting the pertinent ones. General, she denies recent fatigue, fever, weight loss or gain, denies headache, reports decreased vision and inability to read due to cataracts, denies double vision, denies use of glasses, denies hearing loss, denies heart, chest pain or palpitations, and also increased work of breathing, cough, dyspnea, or wheezing. Denies changes in bowel or bladder pattern or function. Denies any arthralgias, myalgias, decreased range of motion or strength, and also denies vertigo, changes in balance or coordination, denies syncope or fainting, denies anxiety and depression. Upon physical exam, she's frail, pleasant, occasionally inappropriately so, no distress, she does look her stated age, vital signs are stable, BMI is within normal limits at 21. Full physical exam unremarkable and within normal limits except for visual acuity unknown. She does have bilateral fundi obscured by dense cataracts. Unable to follow my finger during exam due to decreased vision, however, extraocular movements are intact. Full upper and lower dentures, remaining teeth are in good repair but worn. Cardiac exam revealed a slight sinus arrhythmia. Bilateral upper and lower extremity strength was a 5 out of 5. However, muscularity had some decreased tone and consistency. Most importantly on the physical exam was testing for neurological stuff. She seemed to give, so we went through some communication tests. She seemed to give reliable answers and was fully cooperative. No evidence of any speech disorder or word substitutions. She didn't use any unintelligible words. She can repeat words and sentences with no difficulty and no dysarthria. She's able to name a pen, a watch without difficulty and can write a sentence, but it's messy. However, the sentence still contains a subject and a predicate. Her attention seems to wander occasionally, but when questioned, can be brought back to the conversation. She claims to comprehend everything that's said, although at times her answers indicate this might not truly be the case. She demonstrates appropriate judgment for simple situations, like putting a stamped, sealed, addressed envelope in a mailbox and mailing it out. However, when asked about more complex, concrete situations, she does not have the ability to talk through those. She's alert and oriented times 1, so she knows the correct day, the month, the season. She says the year is 1975. She correctly identifies Harrisonburg, the county, the state. She does not know the names of the hospital or the office. She's unable to copy a drawing. She states it's due to her poor vision and cataracts. Her distant memory, she does know her birthplace, her grade school, names of friends and family. That's intact as far as can be documented, but her short-term memory is poor. She can only recall 1 out of the 3 items that I quizzed her on just 3 minutes ago. Interpretation of proverbs simply consists of repeating words in the proverb. So her motor tone and strength. She is, for coordination, she does finger to nose with some clumsiness noted. She can do alternating movements of each hand performed very slowly, slight clumsiness in the left hand. She can rapidly tap the distal thumb with the first finger. She's able to perform the Romberg with her eyes open only. She can do the heel to shin test with mild difficulty. She cannot do heel to toe walking. No grasp reflex was elicited in her hands and feet. And with her eyes closed, she's able to describe objects placed in her hands and also to distinguish numbers drawn on the back of her hand. Bilateral upper and lower extremity deep tendon reflexes are all a 2+. So for testing, I went ahead and did a eye chart and visual field, which was $113. She was able to unable to read even the largest number on the Snellen chart at 20 feet. She was able to distinguish large block letters with a few errors when held at 14 inches. EKG because of the sinus arrhythmia, and that was $109 according to Healthcare Blue Book 2018, and that demonstrated a normal sinus rhythm with a rate of 91. Did a CBC, did a fasting blood sugar, did a BUN and creatinine, did a C-reactive protein, all of those within normal limits. Slight anemia on the CBC, which can be attributed to anemia of aging, very slight. The only off levels were her vitamin B12 should have been between 180 and 1000, and hers was 141. And then her cholesterol was a little high at 258. LDL was high at 122. HDL was low at 40. At 50. Oh, HDL was normal. I apologize. Her triglycerides were also normal. So she was within normal range for HDL and triglycerides, which is a good thing. We also did an MMSE. She scored a 20 out of 30. 3 points were deducted for her vision. She could not complete due to poor vision. So the cutoff was 24 out of 30 for the MMSE, and this put this patient in a moderate degree of cognitive dysfunction, so moderate Alzheimer's. Potentially, we could evaluate that again after if she chose to have cataract removed, and it may change her score. So that's something to think about for the future. My primary diagnoses, in summary, were 3 things: primary degenerative dementia of Alzheimer's type, secondly, bilateral cataracts, and third, hyperlipidemia. My rationale and differentials for that were, number 1, with the primary degenerative dementia, she presented with signs and symptoms that were not otherwise explained by any other medical, neurological, psychiatric condition. Her onset was insidious. It was 6 months. She did have evidence of cognitive worsening by report. Initial symptoms were affecting her executive function, and she also had a decline in ability to carry out ADLs. She did not have, her negatives were, she did not have any language or visual spatial dysfunction. With the cataracts, I already told you upon exam, those were her pertinent positives. She didn't have any risk factors, but she had the cataracts. And then for hyperlipidemia, I already explained the pertinent positives and negatives based on lab values. The last 2 ones pertaining to cognitive dysfunction would have been mild cognitive impairment. Her positives for that were memory difficulty and objective memory impairment. Her risk factors, she does have hyperlipidemia, lack of medical, neurological, psychiatric condition causing the memory loss. But then her negatives for MCI, mild cognitive impairment, would have been an ability to function with ADLs. You can with MCI, and she was not able to. She didn't have any genetic risk factors identified, like an alpha lipoprotein E, and she didn't have any risk factors like alcohol consumption, smoking, hypertension, or head injury. And then the last, frontotemporal dementia. She did have positives of distractibility, organizational difficulty, and poor judgment, but then her negatives were she didn't have any behavioral disturbances, language impairment, she wasn't apathetic, she wasn't socially inappropriate, she didn't have sleep disturbances or memory spatial, well, she did have memory and spatial skills, but sometimes with FTD, those can be intact, and she did not have those. So we were able to rule that out just on clinical exam. My treatment for her: ophthalmology consult for assessment of cataracts, OT for home safety, eval, home health for ADLs, home health aides for ADLs, and skilled nursing for medication compliance. Also, I want to arrange power of attorney to help with finances and advance directives. I'm going to prescribe a cholinesterase inhibitor, Aricept 5 milligrams oral daily, which is the first-line therapy for treatment of mild to moderate disease, according to Hippocrates. For education, I'm going to talk to her about lipid lowering and possible prevention of AD progression, AD being Alzheimer's dementia. We would want her to have low saturated fat and cholesterol intake and increase her fiber. And then also talking to her about exercising. The American Heart Association says even for the geriatric population, they can, if they're physically capable, which she is according to her physical exam, they can walk at the mall maybe 30 minutes 5 times a week. So if that were possible, that would be something I would encourage her to do. Also, sleeping 7 to 8 hours per night. There's growing evidence that good sleep, such as 7 to 8 hours per night, can be linked to amyloid clearance from the brain, so I gave her that piece of information. Follow up in 1 month for services ordered, and in 3 months for evaluation of services and mental status check again. We'll do the MMSE again at that point. All right, so here's my pearls. Let's see, we did those labs because a number of treatable conditions can exacerbate or cause cognitive decline, like anemia, hypothyroidism, low B12 levels. So I could have ordered a TSH. I didn't because she didn't have any symptoms. Also, as far as the anemia, she may have some mild anemia of aging. World Health Organization defines hemoglobin less than 12 in women as anemia. She was 12.8. According to the DXR, that was low. Nothing to act on. It was just something to keep in the back of my head. Hyperlipidemia, I read about a lead study. This is a pearl. It's called the Lipitor's Effects in Alzheimer's Disease. Tested the hypothesis that adding a statin to a cholinesterase inhibitor could potentially decrease the symptoms or progression of AD. Their hypothesis was disproven. It did not change any of the progression or symptoms. So, plus, in addition to that, the American College of Cardiology and the American Heart Association does not recommend a statin in the age over 75 unless there's clinical atherosclerotic cardiovascular disease, which she did not have. So no Lipitor, no statins for her. Services. VPAS, the local VPAS area, the headquarters is located in Waynesboro. We do have an office here in Harrisonburg. They offer services on nutrition, counseling support, home delivered meals, insurance counseling to help with Medicare benefits, and transportation. The lady that accompanied her said she would make sure that these services were initiated for her through our local VPAS. I ordered OT, home health, skilled nursing. Those can all be ordered through a local hospital. Centera RMH does that. And so I sent a fax over to them. That's a pearl to think about. Power of attorney in your local areas. You can always find a attorney that will specialize in elder care. In our area, it's Botkin Rose. They can help with advanced directives and helping with financial help. So in this lady's case, we would get that arranged for her. Prescribed the Aricept. I did not prescribe vitamin B12 even though she was low because patients over the age of 50 may not be able to adequately absorb vitamin B12. In addition to, it's not been proven to alter cognitive decline or prevent or have preventative or therapeutic effects with AD. So not adding another med in her situation. Last but not least, the Journal of Nurse Practitioners says that currently functional brain imaging is approved by Medicare only when you're differentiating between Alzheimer's disease and FTD, which is frontal temporal dementia, which is one of my differentials. I accidentally ordered an MRI. I didn't mean to. It wasn't necessary. However, it would have been helpful in ruling out FTD, but I did rule that out based on clinical exam. All right, that's